Hi everyone, welcome to MSP. Today we are going to discuss molecularly defined renal tumors. Molecularly defined renal carcinomas included in the latest WHO classifications are TFE3 rearranged RCCs or XP11 translocation RCCs, TFE-B altered RCCs or translocation 611 RCCs, FH deficient RCCs, ALK rearranged RCCs, ELOC mutated RCCs, SDH deficient RCCs, SMARCB1 deficient renal medullary carcinoma. This is a group of heterogeneous tumors with significant morphological overlap. TFE3 rearranged RCCs or XP11 translocation RCC. It is characterized by TFE3 gene fusion with one of many different partner genes. They account for 40% of pediatric RCCs and 2 to 4% of adult RCCs. The survival is similar to clear cell RCC but worse than papillary RCC. The tumor demonstrates papillary architecture, clear cells, and psammoma bodies. Sometimes solid nest with clear cells can be seen. Strong nuclear labeling for TFE3 is highly sensitive and specific. However, TFE3 break-apart fiche is more useful given the less distortion by fixation issues. Occasional tumors express melanocytic markers melan A, HMB45, and cathepsin K is positive in more than half of the tumors. Morphological differentials include clear cell RCC, papillary RCC, clear cell papillary renal cell tumor. Melanin containing entity can mimic TFE3 rearranged pigmented picomas. Unlike most RCCs, these tumors have reduced expression for CK and IMA. TFEB altered RCC or translocation 611 RCC. They are less common tumors as compared to TFE3 rearranged RCC, and they are of two types. TFEB rearranged RCC occurring in younger patients with a median age of about 30 years, and TFEB amplified RCC in older patients with median age of 65 years. TFEB amplified RCCs seem to be more aggressive, whereas TFEB rearranged RCCs have an indolent course with less than 10% resulting in patient death. Both of them display a slightly different morphology. TFB rearranged RCCs have distinctive biphasic pattern with larger epithelioid cells at the periphery of the nest and smaller cells clustered around hyaline basement membrane material in the center of the nest. They also show characteristic entrapment of single tubules at the tumor periphery. TFEB amplified RCCs have high-grade poorly differentiated RCC morphology with prominent nucleoli. The tumor can have solid, nested, oncocytic tubulopapillary features. Similar to TFE3 rearranged RCCs, these tumors also have reduced expression for epithelial markers such as CK and IMA. TFEB rearranged RCCs mostly express melanocytic markers such as melan A, HMB45, and also cathepsin K. Strong nuclear positivity for TFEB is highly sensitive. In contrast, TFEB amplified RCCs less consistently express these markers that are positive in about half of the cases. FH deficient RCCs. FH deficients or fumarate hydratase deficient RCCs are caused by mostly germline or in a subset of tumors by somatic mutations in the FH gene. Familial cases are also known as HLRCC syndrome associated RCCs that are associated with cutaneous and uterine leiomyomas occurring in the third decade, while the sporadic cases lack these features. The tumor has a poor prognosis. FH deficient RCCs typically have multiple morphological patterns. Most common is the papillary, followed by solid, tubulocystic, and cribriform patterns. High-grade neoplastic cells with cherry red-like macronucleoli are common. They can be seen at least focally. Loss of FH staining is highly specific for FH deficient RCCs, while 2SC or 2-succinylcysteine is more sensitive in these tumors. ALK rearrange RCC. This rare kidney tumor is associated with anaplastic lymphoma kinase or ALK gene rearrangement. It can affect both children with sickle cell trait or adults without sickle cell trait. ALK rearranged RCCs are medulla-centric, particularly VCL ALK fusion RCC occurring in children with sickle cell trait. They are associated with good outcome without no recurrence or distant metastasis, whereas adult non-VCL ALK fusion RCCs have adverse outcome. Pediatric ALK rearranged RCCs have a distinct morphology. Neoplastic cells are polygonal with abundant eosinophilic cytoplasm and striking vacuolization. Tumor periphery may show chronic inflammation. Sickle-shaped red cells are more frequently observed in extracellular space. Adult ALK rearranged RCCs are more heterogeneous. They frequently demonstrate papillary and cribriform architecture and desmoplastic mucinous stroma. The tumor may show cytoplasmic vacuolization, scattered psammoma bodies, and rhabdoid morphology. ELOC mutated RCC. These are rare incidental kidney tumor occurring mostly in males with a median age of 60 years. ELOC encodes a protein elongin C that forms a part of VHL complex, which in turn inactivates HIF-1 alpha through ubiquitination. Microscopically, these tumors show branching tubulopapillary architecture and fibromuscular bands. Neoplastic cells have voluminous, clear cytoplasm with prominent cell borders. Neoplastic cells are immunopositive for CK7, carbonic anhydrase 9, and CD10. Morphologically, they can resemble clear cell RCC and clear cell papillary renal cell tumor. Unlike clear cell RCC, they are CK7 positive. In contrast to clear cell papillary renal cell tumor, they don't display prominent subnuclear vacuolization. SDH deficient RCCs. SDH deficient or succinate dehydrogenase deficient RCCs are rare kidney tumor with loss of SDHB expression. Mostly, they have a low-grade morphology and a favorable prognosis. The tumor is composed of sheets of blunt cells with eosinophilic cytoplasm and indistinct cell border. Cytoplasm can have pale and bubbly appearance. One characteristic but inconsistent finding is flocculent cytoplasmic inclusions. Despite being a low-grade tumor, few cases can have focal high-grade areas. Loss of SDHB is crucial for diagnosis. Common differentials include eosinophilic variant of chromophobe RCC and oncocytoma. Unlike SDH deficient RCC, eosinophilic variant of chromophobe RCC has neoplastic cells with distinct cell border, binucleation, and it is CK7 positive with no loss of SDHB expression. Compared to SDH deficient RCCs, oncocytoma is KIT positive and there is no loss of SDHB expression. SMARCB1 deficient renal medullary carcinoma. These renal medullary carcinomas typically occur in patients with sickle cell trait affecting age ranges from childhood to 7th decades of life. They are generally large tumors typically centered in the renal medulla. They are associated with a poor prognosis with a median survival of 8 months. The tumor demonstrates infiltrating cords and nest in a desmoplastic stroma, often with chronic inflammatory cell infiltrate. Neoplastic cells display eosinophilic cytoplasm, marked nuclear pleomorphism, vesicular chromatin, and prominent nucleoli, and eosinophilic cytoplasm sometimes mimicking a rhabdoid morphology. Individual tumor cells necrosis frequently creates round empty spaces. The tumor shows numerous mitosis. Red blood cells, both within the tumor and in non-tumoral area, demonstrate sickling. Tumor cells show loss of SMARCB1 positivity. About half of the cases demonstrate OCT34 positivity. OCT34 positivity makes germ cell tumor a close differential in young patients. Germ cell tumor retain INI1 positivity. Additionally, SALL4 immunopositivity favors germ cell tumor over renal medullary carcinoma. Other differentials in children include ALK rearranged RCCs occurring in patients with sickle cell trait and renal rhabdoid tumors. VCL ALK fusion RCC occurs in younger patients with sickle cell trait and a median age of 9 years. The tumor has a low proliferative index and it retains INI1 positivity. Rhabdoid tumor of kidneys occurs mostly in patients less than 3 years of age without sickle cell trait. Tumor cells may show eosinophilic cytoplasmic inclusion. In adults, main differentials are urothelial carcinoma, collecting dark carcinoma, and other RCCs with secondary SMARCB1 loss. Presence of an in situ urothelial carcinoma in older patients, GATA3 positivity and retained INI1 positivity generally favor a urothelial carcinoma. Collecting duct carcinoma again occurs in older patients. Absence of sickle cell trait, OCT34 negativity, and retained INI1 support collecting duct carcinoma. However, one small subset of these tumors can show secondary loss of SMARCB1.